care, and that is why a lot of medical issues are there when they have to be cared by office-based pediatricians. This CME has been planned in great association with Dr. V.K. Khanna and with inputs from IIP West Delhi, and CME has been made in such a way that the office-based pediatricians, they are able to get some insight on how to take care of thalassemia patients which are coming to them. So beginning with, I invite Dr. Deepak Gautam, President IIP Delhi, to say a few words, and then we will proceed. Dr. Deepak Gautam, sir.
थैंक यू पंकज. सबको नमस्कार और तहे दिल से स्वागत है सीएमई में फॉर सेलिब्रेटिंग द इंटरनेशनल थैलेसीमिया डे, एंड आई वेलकम ऑल द डेलीगेट्स and faculty. Today we have the world class faculty for that. डॉक्टर गुम्बर तो मेरे मतलब टीचर ही हैं, सब कुछ मैंने डॉक्टर गुम्बर से ज्यादातर सीखा है. और तो सर स्वागत है आपका. और पहली टॉक भी आप ही की है, तो मैं ज्यादा देर बीच में कुछ नहीं बोलूंगा. आप सबका स्वागत है एंड होप we'll do a successful CME today. Thank you, sir.
So thank you so much, Dr. Deepak, for those nice words. And now invite Dr. Devinder Gaba, President of IIP West Delhi, to say a few words. Then we, Dr. Gaba, sir.
Thank you, Dr. Gautam and Dr. Pankaj, for giving opportunity to IIP West to conduct this webinar on International Thalassemia Day. On behalf of IIP West, I welcome you all to the platform. As you are aware that thalassemia burden is worst in our country with high mortality. So we have chosen few words: prevention, early diagnosis, and early intervention is the key. Today we have with us top intelligence in the field. I request our most dynamic secretary, Dr. Richa Prashar, to start the proceeding. Dr. Richa, please.
Thank you, Dr. Gaba, sir. I once again want to welcome you all. A very warm good morning to all of you. And on the behalf of IIP West Delhi, I welcome you to this Thalassemia Awareness Day program, which is being organized by IIP Delhi in association with IIP West Delhi. The world honors the courage and resilience of children with thalassemia who are dealing with day-to-day problems, and in the form of and we are celebrating today this Thalassemia Awareness Day on 8th May. There is an utmost need to be aware, to share and care, which is the theme of Thalassemia Awareness Week of this year 2022. And it is our responsibility to promote awareness about the nature of the disease, about the prevention of the disease, and also about how to deal with it. And this year's motto is to impart knowledge. And it is our responsibility to impart knowledge about the disease and to make awareness amongst the public as well as the people who are policy makers. And there's a requirement of the sustained support to all those people who are suffering from thalassemia. And on the behalf of IIP West Delhi, I am privileged to welcome our esteemed faculty of experts who have spent their entire lives, devoted it for the cause. And I also want to welcome and thank Dr. Deepak Gautam, President IIP Delhi, Dr. Pankaj Garg, President IIP, Organizing Secretary IIP Delhi, and our President, Dr. Devinder Gaba. And I also welcome all the participants who have logged in and the members of IIP. And to start the first session, I request Professor Jagdish Chandra Sir to chair the session. Professor Jagdish Chandra Sir is an epitome in the field of hematology. He's the founder of Thalassemia and ART Center in Kalavati, and he had served as a director in Kalavati 2016. He has been a guide, a support, a mentor, and what not to so many students. And I really look up to him as one of my idols. And presently, he is imparting his expert knowledge in ESI, Vasai Darapur. And we are fortunate, sir, that the session will be chaired by you. I welcome you, sir.
Thank you, Dr. Richa, for that very kind introduction, and thank you all the organizers for inviting me to be associated with this session. And as has been said, that first thing about thalassemia is that one should diagnose it as soon as this becomes symptomatic. And the first session very rightly has been titled as how not to miss thalassemia. So what are the clinical pointers? What are the pointers in the routine hematology that you get in children with anemia? and how to confirm your diagnosis. This would be dealt by Dr. Sunil Gombar. As has been said about him, he is a very renowned hematologist, pediatrician in the city of Delhi and outside city as well in the country. And the work that he has done in the field of thalassemia is very well known to us. So without further delay, I would request Dr. Sunil Gombar to start his talk. Dr. Gombar, please.
I
Floor
just
is
good morning, everyone. I think I'm audible. I sincerely thank the IAP Delhi President Dr. Gautam, the Secretary, the Dynamic Secretary Dr. Garg, and my colleagues, the Dr. Gaba and IAP West Delhi branch, in inviting me to speak on this topic of how not to miss thalassemia syndrome. This topic a few days ago only was discussed or told to me by Dr. V.K. Khanna, who is the pioneer in the field of thalassemia, and he was wanting me to speak on the common things that in the office practice, so that we can. It's definitely an important topic. So I hope I am able to do some justice to it. I made the slides in a little haste, but as Dr. Pankaj said, we will discuss it over the slides. So I'll go with the first slide.
सर स्लाइड शो कर दो.
हाँ, कर रहा हूँ. Is it okay? Okay. Now coming on to the next slide, I just start my session with a scenario, because that is what practically in office practice when we come across. So this was a child. Let us say a child is brought 8 months old baby who was born full term. So it was a term baby and brought on a routine checkup to the doctor. And according to the parents, the parents are saying that the child was perfectly normal till about 6 months of age, and after which he started.
Dr. Gombar, just a minute. Slide is not moving.
Sorry. Slide is not moving. कैसे करना है फिर वो?
तो बंद करके दोबारा शेयर कर लीजिए सर.
हटाइए इसे. इसको स्टॉप करके दोबारा करूं?
हाँ जी, एक बार दोबारा शेयर कर लीजिए.
तेल से मालिश भी कर सकते हैं.
अब शेयर कर लीजिए सर.
क्या तुम के तेल से?
Not able to join. He's trying.
Is this okay?
हाँ जी साहब, आ रही है सर, बस just अभी is not started yet.
Sir, Dr. Anupam Sachdev is not able to join. I just received the message. He's trying.
अब आ रही है?
कोई बात नहीं, मैं उनसे बात करता हूँ श्रीचा.
अब आ रही है जी?
अभी हुई नहीं है सर. It's not yet come.
Resume the slide show.
It is started sharing, screen sharing.
Your screen sharing is paused. ये लिखा हुआ आया है.
Paused. तो उसको बंद करके दोबारा ऑन करो सर. तो उसको ऑफ करके दोबारा.
मैं बुलाऊं, किसी को बुलाता हूँ. आपके पास 2 दवा थी.
डॉक्टर अनुपम सचदेव का नंबर मिलाना है. डॉक्टर पंकज बोल रहे हैं.
इस सफेद समय जो उसके यहाँ पे दवा डाली है. तो एक दूध हर कुछ डाल. अब कुछ हो सकता है? क्या करें, पॉज आ गया। आप इसको ले सकते हैं, इसको stop the share, then again down, screen share.
Yes.
Is it okay now? Hello?
Now it is all right, sir.
It's
Yes,
okay.
Dr. Gombar, it's okay now.
Now it's
Yeah.
okay. Thank you. So I just start by talk with a case scenario that in the office practice, most of the time, an 8-month-old or a 6-month-old baby is brought like this scenario. In this scenario, the child was born full term, but is being brought to the doctor or a pediatrician. And when the child is being seen, the child is looking little pale. So the father or the parents are saying that the child is very irritable for the last some time, and he's refusing to take the feed very well. But developmentally, the child is okay for an 8-month-old, like able to say bisyllables, and medical history, past history is unremarkable. So when we see this child in the practice, and the child has definitely got a pallor, but most important thing is when we are seeing a child, important thing in this scenario is the term baby. So usually what happens is that iron deficiency anemia usually occurs in a preterm baby. At this age, of course, it can occur in this next 6 months of age as iron deficiency. But most of the time, if the child is preterm, that means the iron stores get enriched or get stored in the last trimester. So this was a term baby, so we have to look into it, that what is the cause. Now on examination, the child only has got pallor, there is no lymphadenopathy. Lymphadenopathy, why important is because sometimes some sinister diseases like even leukemias or lymphoreticular malignancies, we need to talk about it if the child is pale. But vital signs were normal. Physical examination has got splenomegaly. So a child who is pale has got splenomegaly. Lately, lastly, there were no problems. Next slide. Now, as was being told, now just on examination, we had paleness and the splenomegaly. So in the office practice, we always go in for a Cooter counter, or we go in for a particle counter and going for a hematology. Now, what is important is the hemoglobin was around 10 gram%. That is, the hematocrit is about 31%. Red blood cells were normal. Mean corpuscular volume was low. So that was this was a hypochromia. Red cell distribution width. This is a very important parameter when we are going in for a particle counter. And in this particle counter, the red cell distribution width in this child was normal. So normal is about 11.5 to 14.5. So this child had normal red cell distribution width. Normal reticulocytes, because if you see the corrected retic count, that will be okay. And platelets and leukocytes are important. So whenever we are going to, this is the basic hematology which every pediatrician gets it done, and we must look into it. The important thing here, which we need to know in this hematology, this is that in 10 gram%, the red blood cell count is normal. So normally what happens in an iron deficiency anemia, if the hemoglobin is low, the RBC count would also be low. So this is only the catch which we are trying to find out. So you had a child, 8 months old, that means thalassemia can also present in the second half of infancy. Most of the time it presents in the second half of infancy. Very rarely in the first half of infancy. In a child of 3 months, 4 months, we do see patients of thalassemia, but most of the time this is after 6 months. But the catch here is that the red blood cell count is normal for the age, for the hemoglobin, it is rather elevated. Platelets and leukocytes, we must see into it to rule out any other sinister diseases. And other causes, we must try to rule it out. Any other hemolytic anemia, sometimes the reticulocyte count may get increased. Now, the most important things which I have already enumerated is that you have to look for is the child looking pale? Is your child growing well or gaining weight adequately? That is very important. If the child has not been taking feeds well, it was a preterm baby, there is a problem in the feeding, then the child would also not grow well. So we have to go in the office practice, we need to find out the weight, and we have to find weight for the age. And is the child appetite, supposing, has been decreasing lately? Is the child looking, the belly is looking bigger? maybe because of malnutrition or because of the organomegaly, the child's belly, his or her belly may look little bigger. These are the few things. The child is crying a lot, is very irritable, feeling excessively tired, or suffering from repeated infection. These are the important things we must need to find it out in any child who is very pale. Now, a pediatrician in the office practice should think of the following things always whenever a child comes to us, especially in the next 6 months. In the first 6 months of life, the causes are a little different. You need to find out about the bleeding at the time of the delivery. There was an excessive bleeding? Maybe that because of that bleeding, the child was in the first, or there is some G6PD deficiencies or other deficiencies, enzyme deficiencies are there. Those things present usually in the first 6 months of life. Now, when a child is coming the next 6 months, the pediatrician should think of whether there is any reduced production of a globin chain. So in our setup, the most important thing is that there is a reduced production of the beta globin chain. Iron deficiency, as I said, if the child was a term baby, is a preterm baby, birth weight was very less, or there is a history of a bleeding in the initial period during parturition, then iron deficiency also must be thought in mind. And then we need to talk about the weight, the detailed dietary history, what the child has been taking. If just after the complementary feeds have not been started after about 6 months or around 6 months, and the mother has been giving diluted feeds, then you must keep in mind the iron deficiency. So initially, the important things is iron deficiency and the hemolytic anemia. Cobalamin deficiency is, of course, clinically, the child might come to us in the initial first year of life, especially the B12 deficiency. If it has been noticed that if the mother is B12 deficient, then the children born in the first year of life would be B12 deficient. Even in that case also, you will have a pale child. But then the hematological or the basic hematological, which you see, it has to go in hand, not only the clinical examination, but the basic hematology or the counter findings. They will be totally an outlier, that the MCV will be very high. So those things typically can be found out. There could be thrombocytopenia or there could be pancytopenia. So this is how you should think of that cobalamin deficiency. It can easily be found, easily be diagnosed. Now the red cell these are the causes. Other thing is the red blood cell membrane instability and abnormal utilization of iron, which is not a very common cause. Now, a few brief words. The thalassemia occurs when everybody knows that due to the deficiency of one of the globin chains, and beta globin chain is very importantly there in our areas. So clinical manifestations might range from the minor to severe depending on the number of globin chains defective, whether both the chains are not being formed. So it is 2+ or beta 0, beta plus. So those things are there. But my question was, this is not the right slide. Question is important is that clinically you need to see so that you don't miss. My topic was how not to miss. So a pale child, if there is a history, it's a recessive syndrome. If the history of having taken the blood transfusions being given to another child in the family, that itself also adds on this is a genetic disorder. So it's an autosomal recessive syndrome. So we might pick it up that this is a child, maybe we're dealing again with the case of a thalassemia. Now, the basic hematology, I've already told you that in addition to the microcytic hypochromic cells, peripheral smear is very important. Peripheral smear is always the heart of the investigation. And when the children are brought with the Coulter finding, the peripheral smear, if it shows a lot of target cells, teardrop cells, that is suggestive of a hemolysis, and that gives a pointer towards and as I said, that the red cell distribution width in thalassemia syndromes, especially thalassemia minor, would be normal, whereas in iron deficiency anemia, the red cell distribution width, which is also one of the findings in the basic hematology, it will be much increased. So clinical, this is how you have to take the basic hematology in mind. You have to do the clinical features and keeping in mind, of course, the history of delivery, the history of feeding. So all these things put together, that is how we will not be able to miss a child of thalassemia as early as possible. This is just for the pediatrician's interest, that these are called the teardrop cells and these are the target cells. So basically, if you see a report, you may not see the peripheral smear, but if you see a report with a lot of target cells, a lot of teardrop cells, you should keep in mind that maybe we are dealing with a child of splenomegaly, pallor, normal term baby, unremarkable history, or if there is a history, then it gives us a pointer that maybe I'm dealing with a genetic disease. Now, thalassemia minor, as I said, they are basically they are asymptomatic. They are brought to us. How not to miss that? They are brought to us when they're pale. Child may be pale for that age, but symptomatically, what is happening most of the time is in the practice also, the children are started on iron, and there is a non-improvement of. There is no increase in hemoglobin after starting these children on iron therapy. So at that time, you keep in mind, maybe I'm dealing with a patient of thalassemia minor. They are characteristically, you have, then there are some indices which I'm going to talk about. And the most important thing and most popular index which is seen in practice also is the Menzer index. And Menzer index is the MCV divided by the RBC. That means, as I said at the outset, the MCV will be low. It will be around 50, 60. And RBC count for that hemoglobin would be elevated or normal. So what is going to happen is that Menzer index is going to be, because the denominator is higher and this is already low, the Menzer index would be low. So if the Menzer index coming out to be less than 13, which is a very easy calculable and result, and if it is less than 13, probably we are dealing with a patient of thalassemia minor. The other important thing which everybody, this is one point of controversy which is there, is that you need to get the HbA1c. I'm going to, that is going to be the next slide, that if you have clinically thought of these things, then everybody in office also is asking for an HbA1c. But important thing you must keep in mind is that HbA1c should ideally be done before any first transfusions. It has been noticed that even if one transfusion has been given to the child, the HbA1c, where you see only mainly the HbA2 estimation or HbF estimation, the HbA2, the cutoff level in most of the labs would be 3.5%. And if supposing the HbA2 level is more than 3.5% or HbF levels is more for that age, there is no cutoff like some people are in the habit of practice saying that maybe we are dealing with HbF is, sir, uska na 60 aa raha hai ya 30 aa raha hai, maybe we are dealing with a thalassemia intermedia. So kindly don't say based on only the hemoglobin F estimation that this is a patient of thalassemia intermedia. Intermedia is basically a phenotypic diagnosis rather than a based on hemoglobin F. मैंने बहुत देखा है, बहुत बार reports आती है, and what is happening is the child has received already 1 or 2 transfusions. So I need to talk to my colleagues that please don't give blood. If you have thought of, just don't rush to give blood. Or if you need to give blood because the child is very pale, less than 5%, you kindly get the HbA1c done before the first transfusion, because this is very important. Now, this is what I was talking about, the Menzer index. Now, then the diagnosis, one other controversy is that some people say HbA2 to sir kam ho sakta hai because the child was very pale, and there could be concomitant deficiency of iron as well as, to usko iron deficiency bhi hai, that is why the HbA2 has not risen. Well, most of the studies do say that unless and until hemoglobin is much lesser, that is less than 5 hai, only then the HbA2 gets affected. Otherwise, HbA2 is a good investigation to start with. And agar HbA2 uska bachche ka bada aa raha hai, so you just should keep in mind that this is a case of a thalassemia minor. Basic ek chota sa, this is what I was trying to say, that on examination, history le li humne 80% of the time, as I always say, that you try to find out the cause by history. then medical history, family history of any blood transfusion in the family, then you go for a CBC. When you go for a CBC, basic hematology, I've said, it will be a microcytic hypochromic anemia and isopoikilocytosis. MCH and MCV will be low. Then you go in for the HbA2 electrophoresis, preferably before any transfusion. Go for an HPLC. An important thing, as I've already said, is HbA2. HbA will be lesser. HbA2 will be more than 3.5%. And sometime even in thalassemia major also, you can have a raised HbA2 along with the HbF. So this is not in thalassemia major also, you can have HbA2 level which could be higher. So HbF will be increased for that age, and especially in the early part of the infancy, sometimes it may not be very easy to diagnose, rightly said. That is why the topic is, then you must get the family screen. Supposing you have got a child whose hemoglobin is not rising, there is a splenomegaly, child is about 6 to 8 months of age, and at times the fetal hemoglobin, let us say for a 6-month-old baby, is about 60%. So you do keep in mind that maybe I'm dealing with a patient of thalassemia major. But in the first year of life, it will be better that you get the hemoglobin A2 estimation of the mother as well as of the father. And if the mother and father, as I said, it is an autosomal recessive disease, and if the HbA2 value of both the mother and the father is increased, then you try to keep in mind that maybe we are dealing with a patient of thalassemia major in the first year of life, and maybe we can follow it up later, how the child behaves, how the, if you're trying to keep a hemoglobin of around 9, you may have to give transfusions again and again. So that is how you need to diagnose that maybe I'm talking of a patient of thalassemia. So at times, yes, it is important, and we need to have a molecular confirmation even at the earlier stages. So molecular information to find out the local mutations. Yes, as I said in my lecture, that if supposing hemoglobin is low, we have started this patient on iron, and after that iron, after 2 weeks after about a week, 4 weeks, the hemoglobin is not rising. At that time, we do keep in mind, maybe we are dealing with a patient, as I enumerated some causes, and then you go in for the iron profile. So just don't rush in for the iron profile at the outset, but then after that, you may go in for the serum ferritin value, transferrin saturation, and then you can consider maybe we are dealing with a patient of a deficiency anemia. Usually, as I have already said, HbA2 values will remain higher unless and until the hemoglobin is much, much low. That is, in moderate cases, it does not affect the HbA2 values. Now, iron deficiency anemia, the important thing is, I try to cover that excessive intake of milk, if it is there, the weight for that age of the child is lesser. The milk, only the child is on a milk intake. The iron would be lesser absorbed. Child has not been started on a complementary feeds. Then there may be history that the child has got history of a pica, the easily fatigability, which could be because of the low hemoglobin. So in iron deficiency anemia, the distinguishing point by the basic hematology would be, of course, the MCV would be low. As I said at the outset also, increased RDW. Iron deficiency anemia, you will have an increased RDW. Menzer index will be more than 100 because RBC count itself more than 13, because RBC count itself would also be low. So this is how you differentiate with the basic hematology, that maybe I am dealing with a patient of thalassemia syndrome or thalassemia minor or a thalassemia major. Significant microcytosis generally occurs when the anemia, this is okay. Now coming on to a small little slide which you can get in any textbook, I'll just highlight RDW, the importance of RDW. Iron deficiency anemia, it is increased. Thalassemia minor, it will be normal. RBC count, as I said, which is a matter of the Menzer index, it will be normal or elevated for that hemoglobin, whereas it will be much lower in patients with iron deficiency anemia. Of course, peripheral smear, as I said, again, I reiterate, a lot of target cells, teardrop cells, they are suggestive of You see, a good pathologist will always give you maybe in the peripheral smear, it thoda sa hemolytic pattern lag raha hai. So that is what is the targetemias, teardrop cells. So these are the things after the response. If the child is not improving, only then we go for the iron studies. There is no need to go for iron studies at the outset. Okay, this is I just included. I don't think this is required because it will be MCV will be much higher. But there's not to miss a pale child, anemia, usually not bicytopenias, pancytopenia suggestive of a B12 deficiency. In the first year of life, as I always say, it will be macrocytic anemia, but the cause could be most of the time will be B12 deficiency. And if supposing there is a history of some surgery or going in for the diet, if the child is in a vegan diet, then it could be a case of a B12. This is just a peripheral smear which you not in the office practice will be low, but yes, the reporting will be there that you have hypersegmented polys, you have macrovillosites. That is what is usually the peripheral smear. So peripheral smear, basic hematology, Coulter findings, history, examination will be able to tell you everything. So which you will not be able to thalassemia syndromes. I don't think I'll discuss about it. Spherocytes, this is again in the peripheral smear, abnormal utilization. Thalassemia trait, red cell distribution width, as I have again put it in the red, that red cell distribution width and total RBC counts are typically normal in a patient of a trait. And treatment most of the time is not needed. It is just people start treating them with iron and all, so that's not required. So recommendations are diagnostic workup for microcytic hypochromic anemia. Iron deficiency anemia should always be excluded. That is the closest of the diagnosis. Then this is also, of course, a peripheral smear examination can always tell us a lot about whether this is a peripheral smear of a hemolytic anemia or it is a peripheral smear of a deficiency anemia. So that is all in short I have done, try to do it, but I'll be very happy to take on the questions. Thank you.
Thank you.
Because how not to miss, because we were discussing a lot. Thank you, sir.
Thank you, Dr. Gober, for that elaborate discussion on what are the differences between iron deficiency anemia and beta thalassemia trait and how to make a diagnosis of thalassemia. I don't know if the questions are allowed at this stage or.
Yes, sir. Yes, sir. We can have.
Right now.
Yes, Dr. Richa, are the questions at this stage are allowed or you are?
Yes, sir, they are allowed.
Allowed.
Okay, all right. So if there are any questions, the audience can put in the chat box or ask directly here.
Dr. Gomber, my question, actually antenatal ladies, they come in antenatal period. How not to miss that pregnancy?
Yeah, absolutely. This is a very important question. I did not talk it here, but yes, you rightly said there's a program going on in the Delhi government hospitals also, and even in private hospital, everybody gets it done. And in the first trimester, you must also go in for the HbA2 estimation. So if the mother is going in for, you must try to find it out with the mother is a known carrier or not. Most of the time, mother may not be knowing. तो अगर मदर में HbA2 एस्टिमेशन कराया अपने फर्स्ट ट्राइमेस्टर में और वो उसका HbA2 ज्यादा आया है, तो देयर इज अ गुड पॉसिबिलिटी दैट द चाइल्ड मे बी बोर्न थैलेसीमिया ट्रेट. अगर वो फादर का हो जाता है और वो भी ट्रेट है, तो देयर इज अ 25% चांस दैट मे बी द चाइल्ड मे बी बोर्न विद द थैलेसीमिया मेजर. तो शुरू में ही करा लेना चाहिए. एक समय था, I still remember, I only used to speak a lot about it. Dr. Khanna भी हंसेंगे. We used to talk about nest trough. तो 5 पैसे का टेस्ट है, 10 पैसे का टेस्ट है. So nest trough has come in picture. कि उसमें कुछ नहीं करना होता है because the nature is very great. So what is happening is that the osmotic fragility is not very high. So what we used to see is एक और ट्यूब में बफर्ड सेलाइन डाला और उसमें ट्यूब में आरबीसी डाल दिए. And we used to have a line at the back, white line, black line at the back.
increase on Google Pay for business.
हाँ जी, हाँ जी।
Mr. Go ahead. That was some.
तो उसमें क्या था कि अगर वो लाइन आपको नहीं दिखती है and the RBCs, the blood cells are distributed, so that is called nest rot. But क्योंकि अब तो इतने काउंटर आ गए हैं, nest rot used to be a time 20 years ago, so I never wanted to talk now. It is how the things have changed, because at that time मैं ही बोलता था बहुत ही nest rot कराओ, nest rot कराओ. But that was because I was in a government sector, so in a government sector poor ने वो logistics भी देखने होते हैं. But I think अब तो सारा कुछ MCV based है और आपने HbA2 तक भी कराना है, ये तो अब सरकार की तरफ से ही है. तो जो आपने डॉक्टर गाबा पूछा सवाल, तो फर्स्ट ट्राइमेस्टर में ही मदर का आप HbA2 करा लीजिए और उससे पता लग जाता है.
Right.
Any more questions? Yes, please go ahead.
Dr. Gaba, can I make a comment?
Yes, sir. Dr.
Yes.
Sure.
Sure.
It is important that we realize that the indices become haywire in the second trimester of pregnancy. So you can't really rely upon the indices for making a diagnosis of thalassemia trait, and it is mandatory that you should get the HbA2 done. The reason for that is that in pregnancy, in the second trimester, usually the RBCs are macrocytic. So your abnormally low volume RBCs become a little larger, so it no more is abnormally low. Number two, there is an increase in the plasma volume. So those RBCs increased in number. Because of the increase in plasma volume, that number comes down. So the result is that the indices and the benzers and all those things go haywire in pregnancy, especially in the second week of second trimester of pregnancy. So it is pertinent and important that HbA2 should be done in every case before we take action.
Thank you, sir. Thank you so
Any
much.
more comments, questions?
Sir, why don't we go ahead for both the parents? We should go right away. We should go ahead for HbA2 assessment for both the parents once the conception is there.
बिल्कुल ठीक बात है. अगर आपका HbA2, यही मैंने बोला कि अगर HbA2 मदर का ज्यादा है तो it is always will be very good to go in for of the.
अगर सर मदर का ज्यादा नहीं है तो भी,
अगर मदर का अगर ज्यादा नहीं है
तो
फिर तो थैलेसीमिया होने की संभावना कम होगी ना. अगर मदर ही कैरियर होगी और अगर तो उसमें संभावना ज्यादा होगी, then we can go in for a biopsy. वो ठीक है कि आपके पास में एक तरफ से फादर का भी आ सकता है. That is why the mother is more receptive at that time ना. फर्स्ट सेमेस्टर में मदर आई और टेस्ट आपने करवाने हैं तो HbA2 भी साथ में जरूर करा लीजिए. Yes, वो आपकी बात भी ठीक है कि supposing it is negative, so that means you want to insist that father का फिर भी करा लो.
मतलब we can go ahead right away because in parents are very receptive, especially in a private setup. They don't hassle.
Yes.
So we can get both the parents HbA2 right away.
ठीक बात है.
Now point of care test is coming in for thalassemia also as a slide test, which is known as hemotype slide test. In that, what they are doing is, it has yet not been approved, but what they are doing is that you put a drop of blood and you can estimate HbA2 from that only, and you get the line, just like in a pregnancy test. You get the line and you can make an estimate. Once that comes in, then the cost of this will also go down. Actually, for the sickle cell, there is a big point of care test, but for thalassemia major, they've just started publishing papers on this point of care test.
So I think regarding this, doing the test of the other partner also at the same time, A2, this is already recommended that if you on screening find that the mother is having features in the peripheral blood suggestive of beta thalassemia trait, and you don't have much time, like particularly if it is 6 weeks or so, you do the A2 in the lady and then you wait, and if she is positive, then go for the husband's. So it's better if it is like, say, you do when the screening is positive for the mother, do the A2 of both the partners at the same time. Yeah. So any more comments, questions, or we?
There is one when
box.
asked the value of men's
Dr.
index.
Gomber.
Dr. Gomber, this is another question in chat box. Value of men's in severe anemia.
एक मिनट, क्या कह रहे हैं? Significance of Menzer index in severe anemia caused by thalassemia. Severe anemia अगर iron deficiency anemia है, severe anemia अगर वैसे भी है तब भी Menzer index तो कम होगा ही, less, because RBC count बढ़ा हुआ होगा for that, whether it is severe or moderate. It really does not matter. For 5 gram hemoglobin or for 6 gram hemoglobin, RBC count in normal conditions will be much lower. But for the patients of thalassemia minor, it will be higher. So Menzer index has got nothing to do with the severity of the anemia. So that will continue to be low.
But there would be very rare situation that a thalassemia trait would present with a severe anemia. So in that situation, one has to find the other cause for the thalassemia, the other cause for severe anemia, because most of these children would have said, as you have presented, 10 gram or so hemoglobin, and if 5 gram hemoglobin in a trait would be very, very unlikely.
Yes, it has to be a combination of the anemias, which I said, but then HbA2 estimation will still be higher. पहले वो बहुत सोचा जाता था ना कि HbA2 भी कम हो जाएगा, तो पहले हम
it's not necessarily decrease.
हाँ, तो पहले ये दिया जाता था दिमाग में कि पहले आयरन दे देते हैं और फिर थोड़े दिनों के बाद में कराएंगे. Even pathologists also used to write a report that the HbA2 levels are low, but the peripheral smear में मुझे suggest कर रहा है hemolysis. So Dr. Gomber, I will suggest कि आप पहले इसको आयरन दे दो और after 8 weeks or so हम दोबारा कराएंगे HbA2. Well, most of the studies now don't agree to this unless and until it is too severe. HbA2 will still be higher.
Sir, but the thing is that if we are looking at a CBC report and we get a CBC where there is severe anemia, hemoglobin is like 5, and then we are trying to calculate the Menzer index in our OPD.
There is no
then should
need
we
to
go ahead and rely on that Menzer index when the
नहीं, मैं वही बोल रहा हूँ ना मैडम कि जो Menzer index है, पहली बात तो यही है कि 5 ग्राम हीमोग्लोबिन अगर है तो थैलेसीमिया माइनर का तो ऑलमोस्ट रूल आउट ही हो गया ना मैडम. क्योंकि वो तो होगा ही नहीं ना. ये प्रॉब्लम आती है जब आपका बॉर्डर लाइन पे है, बिकॉज 5 ग्राम, एज डॉक्टर जगदीश चंद्रा राइटली सेड एंड हैज पॉइंटेड इट आउट, 5 ग्राम हीमोग्लोबिन थैलेसीमिया माइनर में तो आने का सवाल नहीं है. इसलिए हमें मेंजर इंडेक्स निकालने की जरूरत ही नहीं है.
Dr. Khanna, your comment? You were saying something.
Thalassemia minors will never have hemoglobin that low. Their hemoglobin normally ranges between 9 to 11 gram %, and it's a very, in some borderline cases and with severe iron deficiency, there is confusion that A2 may be low. Otherwise, we believe that it doesn't affect generally in day-to-day practice.
That's right.
Dr. Anupam wanted to say something, sir.
Yeah, I'm very clear that we will not use measures in any situation except for in mild anemia to differentiate between iron deficiency and thalassemia trait.
Absolutely. Yes.
You have to think that there is thalassemia trait in addition to some other cause. I mean, it may be anything, but thalassemia trait will not cause moderate to severe anemia.
Yeah, never.
का मतलब ही नहीं है. हम तो में जाते हैं, बात करते हैं, तो पेशेंट 7 ग्राम हीमोग्लोबिन है, तो we say don't use Mensers. Do not use Mensers because it is only a discriminant function to differentiate iron deficiency and thalassemia trait in mild anemia.
That's right.
And sir, the concurrent iron deficiency in thalassemia, like sir, Dr. Gomber also commented that initially there was a protocol ki theek kar lo, but there are cases where we have concurrent iron deficiency with thalassemia. So in those cases we should go ahead for treatment.
उसमें वही कह रहा था ना मैडम कि पहले आप हिस्ट्री लोगे, कोई बच्चा प्रीटर्म तो पैदा नहीं हुआ है, वेट फॉर एज उसका कैसा है, हिस्ट्री इज वेरी इंपॉर्टेंट. अगर उसने हिस्ट्री से जितनी उम्र का बच्चा है, सपोजिंग द कॉम्प्लीमेंट्री फीड्स हैव नॉट बीन स्टार्टेड, ओनली ऑन द मिल्क पे है, तो डेफिनेटली यू विल लाइक टू कीप इन माइंड कि ये बच्चे को कॉन्कॉमिटेंट भी हो सकता है. इन दो स्पेशल केसेस यू में, अगर वो बच्चा माइल्ड है तो मेंजर से काफी कुछ पता लग जाएगा, पेरिफेरल स्मीयर से बहुत पता लग जाएगा. Otherwise, you may at times need to give iron for some children, and maybe you need to see the rise in hemoglobin after about 4 weeks to 8 weeks of time. ऐसा होता है.
So the other thing is that if the iron deficiency concomitant is suspected, then iron studies including ferritin would be of help. It's not that only the Menzer and electrophoresis are the things. One can check the ferritin, and ferritin would be low. So I think the signs, the signals are being given that we should close this session. I think it has generated a lot of discussion. Thank you, Dr. Gombar, once again.
Thank you, sir. Thank you.
IIP West Delhi and IIP Delhi for giving me the opportunity to be part of this session. Thank you. Thank you very much.
Chandra sir.
Thank you, Dr. Gombar. Thank you, Dr. JC. Now, the day-to-day care, actually, thalassemics need special care as far as transfusions, chelation, and nutrition is concerned. To talk about this, I invite Dr. V.K. Khanna for the next talk. Dr. V.K. Khanna is a senior, renowned pediatrician practicing in Sir Gangaram Hospital and in Sundar Vihar. With more than 3 decades of experience, currently a vice president of Thalassemic India. He has devoted his entire life for the cause of thalassemic patients. He is a guide and pillar of support to many families, helping them deal with the challenges of the disease. Dr. V.K. Khanna, please. Sir.
Thank you, Dr. Gaba. Good morning, everyone. I'll start with a positive note. Can you
please mute yourself, Dr. Deepak?
Please mute.
गंगाराम से मेरी वाइफ सर हमारे आई हॉस्पिटल नहीं अलग से जी बोलो
प्लीज म्यूट योरसेल्फ
वाइफ बैठी नहीं थी वाइफ में वाला सारा उस दिन सारे हां अभी है
चलो स्टार्ट Am I audible?
You are audible, sir.
Thank you, Dr. Gaba. Good morning, everybody. I'll start with a positive note. That thalassemia is a treatable disorder today that can be well managed with transfusions and chelation therapy. See, that time has gone when we used to believe that, oh, thalassemia, poor child, he's going to have a life of about 5-10 years or so. Now, if they are well managed by optimal treatment, thalassemics can enjoy near normal lifespan and experience, they can have good quality of life, they can develop from childhood to adulthood, and they can become parents also. Can you request them to mute?
Please, everybody, put the mic on mute.
Okay, thank you. This is the thalassemia unit at our hospital, Sir Gangaram Hospital. We give almost 250 transfusions every month. And see, now I'll give some basic information about how we manage thalassemia in the hospitals. Then we'll talk about day-to-day care of thalassemia in office practice. See, as you know that the basic management of thalassemia is regular blood transfusion and chelation of iron. So we start transfusion when the hemoglobin comes down to around 7 and remains there for 2 weeks without any obvious cause of the loss of hemoglobin. And we should not unnecessarily delay transfusion also. And then in some cases, if the hemoglobin is maintained between 8 and 9 grams, there may be a case of thalassemia intermedia. So we decide about the time of transfusion. And then once we have decided about the time of regular transfusion therapy, then we maintain pre-transfusion therapy means hemoglobin above 9, usually between 9 and 10.5 grams. We don't let the post-transfusion hemoglobin go above 15. We don't recommend nowadays going for post-transfusion hemoglobin check because each and every vein of these patients is very precious. We have to give regular blood transfusion every 2 to 4 weeks for the whole life. So we have to preserve their vein. So we don't do unnecessary pricks on these children. And we can calculate also, we can predict that how much will be the post-transfusion hemoglobin. Generally, we say that for packed cell transfusion, like we give 60% packed cells, then about 5 grams, 5 ml per kg of packed cell would raise the hemoglobin by about 1 gram %. So we can calculate how much would be the post-transfusion hemoglobin. And then blood should be as fresh as possible, but not more than 2 weeks old, even if it is stored in the additive solutions. We give 15 to 20 ml per kg of packed cells at the rate of 5 ml per kg per hour every 2 to 4 weeks. And then earlier we were all doing ABO and RH, as you know, compatibility. Nowadays, we do go for extended blood grouping also, C, E, and Kel, so that they don't have reactions. So nowadays, we are giving them fully phenotype matched blood. Many centers in Delhi are also doing, and in big cities, many places are also doing, and it is the standard recommendation nowadays. Screening of donor blood for HIV, hepatitis B, hepatitis C, syphilis, and malaria is mandatory in India. They are doing ELISA 3rd or 4th generation test. Now the recommendation is to go for nucleic acid testing, NAT testing. NAT testing, what it does basically, it reduces the window period. Time after acquiring the germs and the time when they become positive in the ELISA test. So it reduces the window period so that we can detect more and more cases of HIV, hepatitis B, hepatitis C in the donors. Since these patients require only RBC, their hemoglobin is low. They don't have any problem with platelets or WBC. So we give them only RBC, packed cells we give them. So we filter out the leukocytes so that there is no reactions, there are no reactions or there is no transmission of intracellular organisms like CMV. And this leukodepletion generally is done in 2 ways. Either we give bedside, this thing filter, we can use leukocyte filter, or the better method is to remove leukocytes before we store the blood. That is called pre-storage reduction of leukocytes. As we know, our body has no natural mechanism of excreting the excess iron, and each bag of packed cell provides them 200 milligram of iron. And imagine if it is not removed from the body, what will happen? It will get accumulated in various organs of the body, all over in the liver, spleen, endocrine organs like thyroid, parathyroid. Then it can deposit in pituitary, it can get deposited in pancreas, and that may give rise to diabetes in these cases, then ultimately it gets deposited in the heart and there may be cardiomyopathy because of this. So we have to take help of certain drugs called iron chelators, and then we start iron chelator on these chelation therapy on these children when the ferritin is around 1000 nanogram per ml, or they have received about 10 to 15 blood transfusion, and we try to maintain their ferritin below 1000, around somewhere around 500 nanograms. The most important thing with this chelation therapy, since it is a lifelong process, is compliance. So whenever a child of thalassemia comes to you who is taking regular blood transfusion and chelation, please motivate him and check whether he is compliant with the chelation therapy or not, because they just look for a minor reason not to take the medicine on that day, and they have that satisfaction, false satisfaction I would call, that they are taking chelation, but in fact they are suboptimally managed those cases, and they may develop complications. Nowadays we have these 3 iron chelators available. First one to be discovered was Desferol, then came Calfer, Defriprone, and now recently, about 13-14 years back, the last one which came was Deferoxirox, also available as, which is available as Asunra or Defrijet. I just briefly mentioned about their main advantages and the side effects. Desferol, as I said, was discovered and is available since early 80s. Long experience we have, but it has to be given by injection, subcutaneous injection, over 8 to 10 hours. So they take every day injection for the whole life they have to take, and it's a very expensive drug. So then came Defriprone. Then when Desferol was available, only less than 2% cases were getting chelation. Now with the availability of Defriprone, lot of patients are taking, in fact, majority of the patients are taking chelation, and this drug has the advantage that it is orally effective, it is superior in removing cardiac iron also as compared to Desferol, but there is a side effect which can be very serious, and that is it can cause agranulocytosis. So any child who is on Calfer, we monitor CBC on every visit when they come for blood transfusion. In fact, the recommendation is every 1 to 2 weeks. The new drug, desferrioxamine, available as Asunra or Defrijet, is also orally effective. One advantage is that it has got long half-life, so it is 24 hours available in the body. So keeps the bad effect of iron, the side effects of iron, the damaging effect of iron low, and it is somewhere in between. Calfer is the cheapest of the chelators. Now, if a child on chelation gets fever, if he is on desferrioxamine, stop Desferol and look for the cause of this fever and give antibiotics if required. But if a child with Defriprone comes to you with sore throat or with fever, then immediately stop Calfer, because he may be having a granulocytosis or neutropenia. In that case, immediately go for CBC check. Don't wait that it may be viral infection also. And for Defroxirox, the child can continue. If the child is fit to take the medicine, he can continue because it doesn't have any effect with the infection. Here I would like to give you one more clue, that if a child with thalassemia comes to you with oral thrush, just remember that he might be having, just rule out HIV infection. We have seen cases, grown-up children coming to us with oral thrush and they have this thing, HIV infection. Then again, for splenectomized cases also, as you know, spleen gives it has got immune defense function, and then though we give them prophylaxis and vaccination before splenectomy and the prophylaxis, penicillin prophylaxis for the whole life, but severe They are more splenectomized children are more prone to severe infection, more than 50 times than general population. So they can have, if a child with splenectomy comes to you, take it very seriously. If you're not able to diagnose the cause of fever, please send him to the hospital, because they may present with shivering, fever, myalgia, headache, and in hours only, in a short time, they may land up with septic shock, which can very fast progress to multi-organ failure and death. So we generally, whenever a child comes to us with splenectomized child comes to us with high fever, shivering, and the cause of fever, before we get the reports, we start them on antibiotics like cephalosporins and aminoglycosides. It's not moving. And these are the routine tests that we perform every year. We checked on these. Now for child on deferoxyrox, we do SGPT-OT, BUN, liver function and kidney function and routine every month. For CBC, for every case who is on Kelfer. And these are the routine tests. I'll not go in details. We do for all children, and these are the special tests, those wherever certain situation where it is required. Now, how we manage thalassemia at Sir Gangaram Hospital, I'll just say in 2 minutes. Like, we give transfusion on a daycare basis to all these children in 3 shifts. And for the grown-up and those cases who are working, we have night shift also for these cases for blood transfusion on Tuesdays, Thursdays, and Saturdays. Most of our patients maintain hemoglobin above 9 grams per cell, and we supply from our hospital pre-storage filtered blood, which is NAT tested and has got extended cross match. Means that blood is fully phenotypically matched with the patient. And most of our patients are taking chelation, except those who do not require. They are very young. They have just registered with us. They are not taking. Otherwise, all our patients are taking regularly. We run a thalassemia clinic once a week, and there we have one consultant from thalassemia unit, one pediatric endocrinologist, and our pediatric gastroenterologist, pediatric cardiologist, and pediatric surgeon and genetics medicine people are on call. They can be called anytime we need. Now we come to routine healthcare. Excuse me. Now, in office practice, when a child comes to us with thalassemia, they should be given all vaccination in this rush of blood transfusion, chelation. Most of the time, parents would forget about the routine vaccination, and it is our duty to remind them about the vaccinations. In addition, they should get hepatitis A. Though in private sector, we always give all these vaccines, but in government sector, they are not giving. So they should get hepatitis A, chickenpox, pneumococcal, typhoid, and influenza vaccine. As I said, for all splenectomy cases, we give pneumococcal, H influenza, and meningococcal vaccine. Generally, 2 weeks before we plan splenectomy. But in emergency case, we can give anytime. Now, many parents would ask you about diet. Doctor sahab, kya khilana chahiye bacche ko thalassemia? They are so burdened with their chelation and blood transfusion. I'll come to that. With that, we don't restrict, except for those cases who are under transfused. So they should take diet rich in vitamins, minerals, antioxidants like fruits and vegetables. They must take a lot of calcium. I recommend that our thalassemia patients should take 2 glasses of milk every day, and their diet should be supplemented with vitamin D. It is recommended by Thalassemia International Federation that they should be taking 2,000 international units of vitamin every day. Coming to folic acid supplementation, you must have seen that most of our thalassemics take folic acid every day and for the whole life. Yes, they may have folic acid deficiency, and this is more in cases who are under transfused or thal intermedia. because in those cases there is a lot of erythropoiesis going on. By maintaining pre-transfusion hemoglobin above 9, we mean that their bone marrow should be suppressed. They generally do not need that much folic acid. So generally the dose of folic acid recommended is 1 milligram per day. But we don't have folic acid preparations available with 1 milligram. So we have 5 milligram whole white, which everybody uses. So we generally give them half tablet a day or 1 tablet every alternate day. Now coming to iron, that's the most important thing, because whenever we hear this name of thalassemia, we get scared with the iron. Increased iron, we know from the absorption from the intestine is characteristic of thalassemia. They have iron hunger. Whatever they eat, they absorb, unlike normal people. But by giving them transfusion and maintaining pre-transfusion hemoglobin above 8 grams per deciliter, as I just said, that it reduces the iron absorption from the intestine because it suppresses the bone marrow. So dietary restriction of iron-rich food is more significant for those who are either under-transfused or non-transfused, or those who are Thal intermediate. In cases of Thal major, who is on regular blood transfusion and who's maintaining good pre-transfusion hemoglobin above 9 gram %, generally we do not restrict anything in diet except for food very rich in iron, like liver. And the important thing is that we don't give, anyway, nobody gives them iron medication, but there are certain breakfast cereals. You must have seen written on those cereals, Iron Shakti, iron-rich cereals. They should not be given to Thal majors, who, even if they are maintaining pre-transfusion hemoglobin above 9 grams. But otherwise, we do not restrict iron in anything in their diet, except for those who are not maintaining good hemoglobin or those who are not transfused. They should not take iron-rich food. That is very clear. So we should not cook food in iron utensils also. And one thing is that, which nowadays we recommend them, that drinking tea with meals reduces the iron absorption. And this is especially for thalassemia intermedia or under-transfused cases. Now, it was partly discussed, can iron medication be given to thalassemia minors? Whenever we hear this name thalassemia, even if a person is minor, we don't give him iron. But yes, they can have iron deficiency. Thal minor is not an iron loading condition. You may load it by giving extra iron in the form of medication when he doesn't need iron. But remember, thalassemia minors can develop iron deficiency, and if he has got documented iron deficiency, he should be given iron medication also. I'm talking about minors here. And similarly, all ladies, like our gynae friends, they give iron during pregnancy to all ladies. They should be given equal amount of iron also. Other thing in the lifestyle is alcohol. Since our thalassemia children are growing, I find many of them taking alcohol. We always discourage use of alcohol. They should not be taking, because you see their liver is already loaded with iron. So this alcohol can facilitate oxidative damage to liver. And if they have hepatitis B or C, then it can progress to cirrhosis or liver cancer also. So, and alcohol, as we know, that it can increase the chances of developing osteoporosis. Smoking, again, is as such bad for health, and it also increases chances of osteoporosis. A word about osteoporosis. There, in addition to all these things I mentioned, there are so many other causes of osteoporosis in thalassemia. expanding marrow, and then anemia, hemosiderosis, delayed puberty. Very important cause is hypogonadism because they have delayed puberty. Then vitamin D levels low, endocrinopathies, even medication also cause, and lack of activity if they have. So to prevent osteoporosis in thalassemia, encourage them to take diet rich in calcium, and vitamin D supplementation should be given. They must have to go and do regular exercises, and as I said, no smoking, nicotine, or alcohol. And once they develop osteoporosis, we manage it with vitamin D and calcium. Sometimes we give bisphosphonates, and if they have hypogonadism, we give them sex hormones. Now, dental care, non-transfused child or under-transfused child, you must have seen their faces. They get hypertrophied maxilla. This can be prevented by giving timely transfusion and maintaining pre-transfusion hemoglobin above 9 gram per cent. But if the transfusion is started late, or if they are under-transfused, then they get these proteins. And when they grow to the age of puberty, then they come to us, doctor, can we go for that orthodontic treatment and all that? But we must keep in mind that and rule out osteoporosis, because it may lead to loosening of teeth or may lead to fractures also sometime in the maxilla. And very commonly asked questions from our dentist friends is that go and get clearance from your doctor because your child has got thalassemia, he may bleed more. So remember, thalassemia, they probably confuse it with hemophilia, I think, because thalassemia is a hypercoagulable state, thrombogenic state. It is not unless the patient has got low platelet because of hypersplenism or so, otherwise they don't bleed extra in any of the dental procedures. So we give them clearance after seeing the platelets. Now, physical activity, sports, can they take part in sports? They must be asking you these questions every day. Exercise, we know, stimulates growth of muscle and bone. Very good for our body. We always encourage them to go for exercises, and they must participate in the games in the schools and at home also. And the sports, they can participate like swimming, aerobics, brisk walking, jogging, cycling, yoga, and all other indoor sports they can participate. Another question they may be asking you, can our child go to gym? Yes, they can go to gym. And they can go there and do stretching, stepping, treadmill, cycling. Adults, as the recommendation is, standard adults should walk about 10,000 steps a day. I saw somewhere recently, so I thought I'll keep it on the slide also. And young girls and boys should walk about 12 to 15,000 steps a day, because most of the time they are having those watches which can count the number of steps they walk. So these are the number of steps they should walk in a day. When they are going to gym, they should avoid heavy weight lifting, jumping, bending, and twisting. Like they should not be having a thirst on their body. And while participating in the sports, they must avoid contact sports, like outside they say rugby, and in our Indian we can say that wrestling and all those things, because if they have hypersplenism, then it may lead to trauma and rupture of the spleen. I always give example of this man, Gabriel Theophilos. He is a Thal major. Imagine at the age of 33, he participated, Dr. Pankaj, are you there? Participated in the London Marathon, 42 kilometers in 2006. And after 7 years, he broke his own record. He's a thalassemia major. Coming to education, these children, thalassemia children, should be enrolled in the normal schools. They are very intelligent, and I feel that they are very bright children. They should not be segregated there like weak members of the society. They should not be isolated. They must be given chance to participate in the school, all school activities like drama, sports, everything. And we don't want to be them to be called bechara, Bichara thalassemia. No, they are not bicharas. They are like any other normal child, and they must be given chance to participate in all school activities, and they are doing very well in education also. As far as profession and employment is concerned, well-managed thalassemia, they do not have any difficulty in doing any kind of work unless osteoporosis, fractures, heart disease, something limits their activity. Otherwise, no, well-managed thalassemia can perform any kind of work. They can do any job. In our hospital, out of 156 patients registered for regular transfusion, we have 90 patients who are adults, more than 18 years. And out of them, 56 are earning. They are supporting their family. Marriage and reproduction, I think I'm coming to the end of my talk. Marriage and reproduction. See, when we started work on thalassemia about 35, 36 years back, it appeared a dream that our thalassemia cases would get married anytime in future. Now they are growing. As I said in the beginning, in the first slide, that with the modern treatment, with the optimal treatment, they can have a near lifestyle and near lifespan. So they get married, they can get married. Many of them have spontaneous fertility. If not, if they are infertile because of hypogonadism. You see, most of them have hypogonadotropic hypogonadism, means their hypogonadism is pituitary driven. So if we give them gonadotropin, they get treated. Many of them, they get treated. In our unit, out of 90 adults, 26 are married and 10 have children also. Driving, no restriction. They can drive anything, anywhere. Now traveling, they must be coming and asking you, can we take our thalassemia child to hills? Can we go to this place? Can we go to that place? Yes, they can go anywhere like any other normal person, but they have to make few arrangements. Like they have to coordinate their travel plans with the transfusion schedule so that they don't need transfusion outside. If they are going for week, 10 days, 15 days, they should take transfusion and keep hemoglobin high enough so that they don't require this thing, a blood transfusion there. They should take travel insurance. Though in India, insurance does not cover thalassemia, but insurance, remember, insurance covers anything other than thalassemia also. Like if they are going outside and they get typhoid or any other disease and they get admission, then insurance will cover them. Now, visiting high mountains, before going there, they should check their fitness. We should get their echocardiography done and look for ejection fraction and look for pulmonary hypertension and so. And when they go to high hills, they must allow acclimatization. Have high hemoglobin, check your cardiac fitness and acclimatize. That is what we say. For splenectomized cases, they should travel to areas where they should not travel to areas where there is risk of malaria, because in splenectomized cases, malaria can be very severe and they should avoid, or if they are going there, they can take chemoprophylaxis. And splenectomy patient should always, whenever they are traveling, they should ask their doctor and carry the antibiotics. These are pictures from our neighboring country, Pakistan, where they took thalassemia cases to a height of around 12,000 feet to the base camp of K2, Nanga Parvat. And lastly, psychological issues, because there is still a stigma attached to this disease. Whenever somebody sees, oh, thalassemia, that's why you will find many thalassemia patients hesitating to tell their diagnosis, because people still feel that, oh, they are little different. And because of the load of treatment, many of them have psychological issues also, like depression is the most common. Then they have anxiety, emotional disturbances. And to make them all right, they should maintain good hemoglobin. We should not overprotect them. You see, in the families, there is generally a tendency that if there is a thalassemia child and parents would give him more protection, ye bhi mat kar, wo bhi mat kar, main kar deti hu, ye kar deta hu. No, they are like normal children. They should not, because overprotection spoils these children, and then it affects the interpersonal relationship with the siblings also. And we must help these children to accept the illness. Now, coming to 2-3 slides on COVID and thalassemia. Are thalassemics more prone to COVID infection? No, they are like any other person. They are not more prone to COVID infection, but they are more exposed to COVID infection because they're going to hospital for transfusion, for their checkups, for blood tests. So their exposure is more, but as such, thalassemia does not predispose them to COVID infection. Are thalassemics at higher risk of severe COVID infection? No, not. But if they have any complication or comorbidity like cardiac disease, diabetes, or other problems, then definitely they can have severe infection. Another question they ask is, can COVID be transmitted through blood transfusion? I think by this time, most of our thalassemics know that it is. There is no evidence till date that it is transmitted through blood infection. So if in case they ask you, can COVID get transmitted, please tell them that it is not transmitted. And lastly, vaccination. All eligible thalassemics should get the COVID vaccine. Whichever vaccine is available, no problem. They should get the vaccine. COVID vaccine can be given concomitantly with or any time before and after any live or attenuated vaccine. There's no problem with that. But though our recommendations say here that we should keep a gap of about 2 weeks before with the other vaccine, we can keep that so that there is no confusion which vaccine gave the side effect. And can COVID vaccine be, what time is COVID vaccine should be given in relation to the blood transfusion? You can give any time they can give blood transfusion, but generally we say that it should be given after few days of blood transfusion or before few days, so that in case there is a blood transfusion reaction or any side effect of COVID vaccine, there will be confusion and will not come to know. Otherwise, there is no problem. So to conclude, I would say that with the current management, it is possible for thalassemics to achieve a near longevity and a good quality of life. Thank you.
Thank you, Dr. Khanna. Thank you very much for this lucid talk. And one question, sir. Do you agree that we should go for echocardiography or MRI scan routinely?
Routinely, MRI scan is done once a year after the age of 10 years. Earlier, we used to say, now we say after the age of 8 years. And if it is normal, then every 2 years. But I couldn't follow your question. You want this routine monitoring, you say?
Yeah.
Echo is a part of routine
Echo.
monitoring. Yes, we are doing like ferritin is a very good guide, but ferritin has got its own limitation because it's the trend of ferritin is reliable. We don't take one value as such of ferritin because you may have ferritin value 1 at 2000, and if child picks up any infection or anything, next time you may find it 5000. So it's not reliable. We see the trend of ferritin level. Then as far as cardiac monitoring is concerned, we go for even ECG every year. Then echo, there are some findings which echo can tell, MRI cannot tell. And remember, changes in MRI are very slow. So MRI cannot be performed repeatedly. So we go for MRI. MRI actually gives you mainly the quantitative assessment of the iron in the heart. Mainly we do for that. And echo has got so many other things you get from when you do the echo, like pericardial effusion, pulmonary hypertension, and so many ejection fraction, then this thing, diastolic dysfunction, so many things we come to know. So echo is an essential part of the routine monitoring of thalassemia cases.
Right, rightly, sir. Thank you. Any other question, anybody?
Dr. Khanna, sir, one question. Those
Yes.
thalassemics who want to participate in competitive sports, like
Yes.
suppose want to do, so are they hypertransfused to keep their hemoglobin on higher side like 12, 13, 14, or their management is like any other thalassemic?
No, more. See, we maintain, if they maintain hemoglobin above 9 grams, they are reasonably active. They can do anything. Only thing is, we have to take care of the osteoporosis they have. Then we have to take care of their heart. That should be normal. And they should not be under transfused. More important is under transfusion in India. There are many hospitals still, you will find that they give transfusion only when the hemoglobin drops to 7, 6, like that. They believe probably that if you give more blood, more iron chala jayega, फिर chelation ज़्यादा देनी पड़ेगी. But they don't realize that will affect the growth of the child. That will increase the iron from the gut. So many side effects it will have if you maintain low iron. But for competitive sports, they can have they should have their hemoglobin around 10. That is what we say, 9 to 10.5, and they can participate. But contact sports, definitely we tell them to avoid.
And sir, one about vaccination. Even we books tell us that
yes,
response to hepatitis B vaccination response is not very good in thalassemics. So is it routinely you should do anti-HBs antibody in them, or?
Yes, we do that. That's one thing I was expecting, Pankaj, because see, their response to some vaccines may be blunted. If you see, so anyway, and we know that their response to hepatitis B starts going down after few years. That is there in general public also, but since we say that there is memory, and then it generally, when you get exposed to wild virus, it generally comes up. But for thalassemics, we monitor their anti-HBs antibody every year, and we try to maintain it above 10. Like when they come down to around 10, 15, we give them a booster shot. Earlier, they used to say booster every 5 years. You will remember when hepatitis was introduced, it was said that booster every 5 years. Now, for general public, they don't recommend boosters. But for thalassemics, we say that we should monitor this and maintain, because they get a very big dose of, in case, though nowadays we are screening donor blood so thoroughly with the latest 4th generation ELISA, and nowadays many hospitals are doing NAT tested. In that situation, the risk of transfusion transmitted infection is very low, but still that theoretical risk is always there. So we keep them protected by maintaining the high anti-HBs values.
Thank you so much, sir. Thank you, sir. And an excellent talk as always.
Yeah. Thank you. Thank you, Dr. Kannad. Thank you so much. Dr. Richa.
Thank you, Dr. V.K. Karnakar. It was an excellent talk covering all the aspects of day-to-day care of patients. Very practical. For the last session of the day, I now invite Dr. Anupam Sachdev, Director of Pediatric Hematology Oncology, Sir Gangaram Hospital, a master and pioneer and researcher in stem cell research. And Sir is a recipient of many awards, James Flett Award, BC Roy Award, and recently National Excellence Award in the year 2014 and 15. And he's an excellent teacher, counselor, guide, and my mentor. I welcome you, sir, for the last session of the day.
Thank you, Richard. Thanks a lot. For this session, we have Dr. Amita Mahajan, who's a great teacher as well as a great clinician. She is the senior consultant in pediatric hematology oncology from Indraprastha Apollo Hospital, and one of the teachers who has started an FNB program and is running it very well. Dr. Amita, could you please put on your slides and share them with everybody?
Are my slides visible? Are my slides visible?
Yes.
Yes.
Yes, ma'am. There is.
Thank you, Dr. Anupam. And I'd really like to thank West Delhi IAP for giving me an opportunity to interact with all of you today. But more importantly, for giving Thalassemia a platform on this International Thalassemia Day. I'd also like to congratulate Dr. Khanna on his wonderfully positive presentation. And what we try to do as a hematologist or thalassemiologist is to change the perception about thalassemia. तो अगर मुझे डॉक्टर खन्ना ने मुझे बोला आज बोलने के लिए recent advances पे, so let me start by saying the recent advances, the way we think about thalassemia now, the way our attitudes have changed. And this topic is important because within our pediatric hem-onc community, most of our younger colleagues find thalassemia as the least glamorous field, and इसमें कोई नई cool research नहीं होती. So I hope that in the next 10-15 minutes, I can change that perception for you, because really in the last 1 or 2 decades, there has been an explosion of clinical transformational research in this field, and which really has the potential to change the quality of lives of our thalassemic patients in the years to come. We all know that it is the commonest monogenic disorder, and of the 60,000 new patients with thalassemia every year across the world, 1/6 of them are born in India. And that is something we say with a lot of pain, because when each of us, when we joined medicine, this was the figure that was given to us कि हर साल 10,000 बच्चे पैदा होते हैं. And after 25-30 years, that still remains the figure. And Dr. Pankaj Garg was there, Dr. Khanna was there. We were all together at a thalassemia platform where we were just seeking commitment from our obstetric colleagues to work on this, because this has to change, and let this be the year that the change begins. Prevention is the key. But at any rate, we have a large number of thalassemia patients, and there will still be more children happening. So the recent advances, really, like I said, have the potential to change their lives. So what are the 4 approaches when we look at management of a thalassemic child or patient? So this, we have the conventional therapies, the iron chelation and transfusion that each of these patients will receive. And we have, on the other hand, approaches which are looking at inducing fetal hemoglobin, because if you increase the fetal hemoglobin of an individual with thalassemia, their clinical severity of the disease is reduced. So these 2 approaches are, aimed at improving the lifespan and quality of life. But on the other hand, we have the approaches which are potentially curative, that is the VMT and the gene therapy. So I'll just talk about each of them a little bit over the next few minutes. So fortunately for us, even though the numbers don't seem to diminish, in all these 4 areas, new research is happening, which is very exciting to us in working in this field. So let us begin with transfusion. Dr. Khanna already said that all good centers today are trying to give NAT tested blood. So what does the NAT testing blood do? It shortens the window period, because when we do the normal ELISA testing, still many patients will get hepatitis B and C because of the the window period where we cannot detect infection in a donor. When I started our thalassemia unit, when we analyzed our first 100 patients that were taken from any center in the city or North India, 30% were hepatitis C positive. So it was a problem. But I must say that since we switched to, since that time to today, we've not had a single seroconversion of hepatitis B or C. And that is significantly because of NAT tested blood, which reduces the window period for hepatitis B to 10 days, for hepatitis C, which is a bigger problem, 1.34 days, and HIV to 2.93 days. So thereby, drastically diminishing the risk of transmission. Leukodepletion, pre-storage, which most of the centers are able to offer now, takes away all the, the febrile reactions, the shivering, and all those other reactions that used to happen with transfusions before. And Dr. Khanna already mentioned, when we give extended phenotype matched blood, we reduce the risk of alloimmunization, and thereby they can continue to receive same blood for a long time. So is there anything that we can do to actually reduce the transfusion requirement, which is every patient's and every family's hope and dream? So, and a lot of work has gone in, and I'm happy to report that we recently received FDA approval for this agent, luspatercept, which helps in reducing transfusion requirement. It's a subcutaneous injection that is given every 3 weeks, and it can induce a dose-dependent improvement of anemia. And of all evaluable patients in the studies that led to its licensing, there was in excess of 40% reduction in the transfusion burden over any 12-week period. It also helped in dramatically improving chronic leg ulcers that some of these patients, especially the non-transfusion dependent patients, get. It's well tolerated. There were no notifiable side effects, and it's currently licensed for individuals above 12 years of age. None of us have used it in India as yet. We can import it, but the cost right now is prohibitive for us. But it's just a matter of time, like we've seen with other generics. The window between an innovator product and generic product coming to in the hands of our patient is getting shorter and shorter and shorter. So we're very optimistic that in the very near future, hopefully, our patients will also have access to this agent. With the burden, transfusion burden, comes the burden of chelation. Dr. Khanna already mentioned how we chelate, how we go about to it. So what is new in chelation? The efficacy of chelation depends on compliance. And here we are talking about taking something prophylactically lifelong to prevent excess iron overload. Let us all look into ourselves that how many of us have completed a 1-week course of antibiotics. I know I haven't. The moment I have felt better, I've just forgotten to take my antibiotic or even any other medication. And here we know we get upset when our patients are not complying, because the compliance and to ensure compliance is really our biggest challenge. So to help with that, we had this agent, which is from all night infusions, we came to oral capsules, but there were still multiple capsules to be taken many times a day with significant side effects. But in the last few years, we've had this tablet, simple oral dispersible tablet, more effective than both of them and less side effects than more of them. And I think this drug has really been transformational for those on transfusion and chelation. But even with this tablet, the mixing and, there are issues. Like I said, just taking anything regularly, especially in teen years and in young adults who are busy jobs and busy social lives, compliance falters. So to make this even better, we now have this film-coated tablet where there are no, dietary restrictions before meals, after meals. You can take it anytime and you can just swallow it. So the importance of this drug is that, there were studies, it's been well evaluated, that the little GI effects that we had with the other preparation, they are minimized with this. The time to prepare medication, waiting time to eat and thinking about, can I just avoid it today? These are much lesser with this tablet. It's a simple thing, same salt, just a different preparation. And in generally, for any other drug, it would not matter. But for where a thalassemic has to take it day in, day out, just making even this little bit simpler has really helped. And because how it has helped, that in the studies, it showed that the compliance and adherence to this preparation was significantly better. And all this led to actually more efficacy because the salt is the same. In fact, we give lesser doses because the bioavailability is better. But the change in ferritin or reduction in iron overload was superior only because I think it's just easier to take and compliance and adherence were better. Are there any other new chelators on horizon? Well, not in the immediate future, but work is ongoing. But we accidentally found that a drug that we use for ITP actually has a chelator effect. And that is something that we can evaluate whether it can be combined to these agents and it may give us additional benefit, but that is ongoing. Monitoring, how have we progressed? Like Dr. Khanna said, we monitor serial ferritins, but there is a lot of reasons why ferritin is not the best test, but T2 star MRI, that has again helped us in understanding iron overload much better. So here on the left, you can see patients who, who have very little iron load, some iron overload and high iron overload, where it becomes darker. The interventricular septum, that is where we measure the iron overload. It's a very visual medium. It helps us to convey to our patients, see what is happening in your tissues and in this thing, why it is so important for you to chelate regularly. And I think that also helps us in improving their compliance. It has significantly prognostic information. So if the cardiac MRI is very poor, we can predict that within 1 year, this patient is going to go into CHF, and we can actually work with them to prevent that and effectively reverse, because cardiac iron overload is completely reversible. Again, we can do the same thing to the liver. So you can see in the ground chart that as the iron load over in the liver increases, it becomes darker and darker, and you can assess it quantitatively. So it's just a test. How can a test improve anybody's life? Well, it does, because since the cardiac and MRI was introduced, the chances of patients going into congestive heart failure reduced dramatically, because it's a very visual medium. You know, mere body ke andar kya ho raha hai. It really stirs you on to reverse that. And that's why just as an investigation which has the potential to change the outcome of the patient. Actually, to do it properly, you need a very expensive software. No hospital wants to invest in that, because we ask them to give only discounted tests for our patients. So now there are innovative softwares which our radiological colleagues are using, so that they don't have to pay anything, and they are as accurate as the original innovator software. It's a very brief 7 to 10 minute MRI, and the cost is again very much lower than a regular MRI. What about transplant, which is the curative treatment? We all talk about it a lot, because the results for transplant in India over the last decade or so have improved so much that they now match the best centers in the world. The first successful transplant was done in 1981 for a 14-month-old girl. And that really, it was a big news at that time. And today we take it for granted, but it was big news at that time. And the first major results came nearly 30 years ago from the best team in the world, Ducarelli in Italy, and where they showed that with transplant, more than 75% went on to live thalassemia-free lives, healthy lives. So this was a very big news, and literally this is curative treatment. So you can finish everything. In this graph, you can see today that the results for thalassemia transplant are very encouraging. But they depend that ideal time to do is less than 10 years of age in a child who's well chelated and has no organ dysfunction. The donor matters. So the best results are with a matched family donor, but from a matched unrelated donor from the Indian or the international registries, these results are now matching that of family donors. For those who are very keen on transplant, there can be a mismatched donor from the family. And the results for these are inferior, but they are also improving. And as they get better and better, you can see that every child will have a half-matched donor in the family. So every child could potentially opt for this treatment. But the results are still little inferior, more complications than a fully matched donor. And that is, many teams are working to enhance these outcomes. Gene therapy is something we've all been listening. Jab se we joined medicine, gene therapy aane wala hai, kuch hone wala hai, transplant. It was disheartening for many years. In fact, the research in this field went down. But in the last 10 years, there has been, with the new genomic editing and other new, explosion of new research in genomics, this came back into focus. And I'm pleased to report that we are now seeing successes even in this field. For the gene therapy, the principle is simple. You extract the patient cells, you modify them with some kind of genomic transfer or genomic editing, and you transfuse this cell back into the patient so that they are now free of thalassemia. So the two techniques that have been used are gene transfer with using some kind of viral agent, and lentiviral based gene transfer has been the most successful in this area. It was licensed in 2019 for patients more than 12 years of age who were candidates for BMT but don't have a donor. But the more recent one, and this was a very big news last year for us, that there was CRISPR-based genome editing, and 5 patients were presented in the big international hematology meeting, all of whom by 1 year of this procedure were transfusion free. So more research, it's not yet licensed, it's still in a pre-licensing stage as we are waiting for more data and for this data to mature, but this is encouraging. The problem with this is that the cost today, if somebody were to go for it, is really prohibitive in many crores and way above the cost of transfer. But again, encouraging work is ongoing in India at CMC Vellore under the leadership of Dr. Alok Srivastav. And at every year, he gives us a little bit of an update as to where we are with this. So we could look forward to maybe something happening, but at the moment, this is not an option for our patients because of the prohibitive cost. One area that there has been a lot of interest is that could we, induce fetal hemoglobin? Because if the fetal for patients we know who naturally have thalassemia with a high fetal hemoglobin, they appear to have a much milder disease. So could we artificially improve their fetal hemoglobin and achieve the same result? This thus shows that for patients with thalassemia intermedia, their severity depends on their fetal hemoglobin level. So a number of agents have been tried, but the most interest has been with hydroxyurea, some of the newer agents or agents that we are repurposing in thalassemia, and I'll share that with you a little bit. So hydroxyurea was initially tried in sickle cell disease and subsequently in thalassemia, and we routinely use it in all our non-transfusion dependent thalassemia. The response has not been very encouraging in thalassemia major patients, but there is now again renewed interest that could we combine it with something else and get that result if it's not so powerful alone in transfusion dependent patients. So one of the agents that has brought about a lot of interest is thalidomide. It is a very old drug, was banned because it was used was the teratogenic effects in pregnancy, but for the last two decades, it's being extensively used in hematology and oncology for a number of indications. So the first report of its use came from two different groups which had to give it to patients who were in a very desperate situation, had very high antibodies, and they could not match any blood for them. So as an immunomodulator, it was tried and the patients became recovered from that and remained transfusion independent. So this was very exciting. And subsequently, a lot of people started using it. Within our country, we strongly felt that this is, we need to understand the use of this drug in thalassemia more. And we shouldn't just start giving because we have to give it to our patients for many years, maybe lifelong. So after a pilot study done by Dr. Chandra at Kalavati Saran, which has shown promising results with a good response rate in 60 to 70% of patients, we are now ready to roll out this study, a multicentric study, and we've got DCGI approval to do the same. And this study should be rolled out very shortly, maybe before the end of this month, to see which patients respond, what is the right dose, are there any side effects, and it will be done in a very controlled setting. Very cheap drug, and if it can reduce the transfusion requirement, it may actually match the benefit that we see with the subcutaneous injection that I talked about. There are other agents which have been tried, are not so helpful in increasing the hemoglobin, but have been very helpful in reducing the spleen size, which sometimes becomes a problem for these patients. There is ongoing research in a number of natural HbF inducers, but this is still in a very preclinical setting. So I started by saying that, what has really changed? All this research has come. It makes us feel very optimistic and hopeful. But what has really changed is the attitudes of both the patients, the families, and their treating doctors. So let me end by these case studies of two patients. This is a 50-year-old male, optimally chelated. His ferritin is consistently less than 1,000. He has no organ dysfunction. He's a very successful businessman. In fact, we have to manage his transfusions around his international trips that he makes for his business. He's married and a father of 2 children, and I can say with confidence that he will definitely outlive me because he seems to be healthier than I am. And you need to bear in mind that when he was diagnosed with thalassemia, his family told me that they were told that why do you want to work on this child? दूसरा बच्चा कर लीजिए, what life he will have, and this is the life they have given him. I think I give entire credit to the family and parents of this child. This lady is 38 years old. She was an IT professional, but after her family, she is now running her own startup business with these two beautiful children. No organ dysfunction and no reason why she should lead a healthy, long life. So this is what gives us hope and optimism. And these two, they managed this with none of the advances that I talked about. So let us just imagine that what the future can hold for. Of course, we don't want more children with thalassemia to be born, but the dynamics of our healthcare in our country dictate that it will be a long time before that dream comes true. So till then, this is the life we can at least give to our patients. Once again, thank you so much for giving Thalassemia a platform. This is the logo for this year: be aware, share, and care. And thank you for having Thalassemia on this meeting today. Thank you so much.
Thank you, Dr. Amita ma'am. It was a wonderful talk. And the best part is that the attitude has changed. And the last two cases that you showed really raised our hopes that we can lead a normal life, because these people, they are already worried about what will happen of their physical state of body. So they are more concerned and they're more active and they want to work upon it. And I congratulate the efforts of each and every member who has actually devoted their lives for this cause and for a wonderful session. And I want to thank everybody, all the esteemed faculty, our chairperson, speakers, for this wonderful session. I also want to thank especially Dr. B.K. Khanna, who was the chief coordinator for the program. My special thanks to our chairpersons, Dr. Jagdish Chandra sir, Dr. Anupam Sachdev, and Dr. Gaba, and our esteemed faculty of speakers, Dr. Amita, Dr. Gombar, and Dr. Amita Mahajan. I want to extend my thanks to Dr. Deepak Gautam, President IIP Delhi, and Dr. Pankaj Garg, Organizing Secretary, for this giving us this opportunity, and Dr. Devendra Gaba for his untiring support. And to all the members who were so interactive on this session, to all those who have logged in and spared this time. And I really want to congratulate the resilience and courage of the thalassemia families and children who are dealing with their day-to-day challenges. And I want to congratulate each one of you on this Thalassemia Awareness Day. Thank you.
Thank you. Thank you, everyone.
Thank you, Dr. Pankaj. Thank you, Dr. Gautam. Thank you, everyone.
Thank you so much.
Okay. Bye-bye.
Thank you, Dr. V.K. sir. Thank you.
Thank you.